Good morning, everyone. This is Donghoon Choi. I'm the chair of this live session, live case and lecture 7 session, EVAR session, and let's start the live session from the Severance Hospital, Seoul, Korea.
Okay. Good morning.
Good morning,
Can you hear
Dr.
us?
Ko. Yeah.
Yeah, good morning. It's my great pleasure to have the opportunity to demonstrate our live case. So let me introduce my team. On my right side, Dr. Seung-Jun Lee is my junior colleague. And we have also Dr. Bo-Kyung Jeon. She's a fellow in our CAS lab, in our intervention division. And we have a good team of nurses and technicians, and also our anesthetist is helping us to sedate the patient. So, Dr. Lee, could you introduce our case?
Yes, thank you, Professor Ko. Today I present our EVAR case. It's Severance Hospital, South Korea. Next slide. The 70-year-old gentleman presented with incidental finding of the abdominal aorta and bilateral iliac artery aneurysm on his CT scan. Previously, he has underwent chemotherapy due to the small cell lung cancer involving the entire segment of his lung. In the left finding showed normal finding. Next slide. This is the CT scan. In the 3D reconstruction view, you can see the huge AAA, which is the fusiform, and you can see the bilateral involvement of aneurysm. In the X-ray scan, the AAA diameter was about 62 millimeter. The proximal leg length was 23 millimeter with the diameter of 23 millimeter. And as you can see, the both sides of the iliac arteries show aneurysmal finding exceeding 35 millimeter. Next slide. This is the reconstruction image of the both sides of the iliac arteries. The proximal neck diameter was about 22 millimeter, and you can see the both sides of common iliac artery shows aneurysmal findings. So for the internal iliac artery, left side shows about 18 millimeter, shows aneurysmal finding, while the right side shows the 90.5 millimeter diameter, relatively normal. So the both sides of common femoral arteries was shown to be good. So next slide. So this is the treatment option for this patient. So open referral, he has the very reduced lung function due to prior chemotherapy and lung cancer. So he might not endure the general anesthesia. So we can consider EVAR, and the second option is classically bilateral iliac artery embolization and the EVAR. And third, using the iliac bracing device. So
yeah. So in summary, this is a 70-year-old gentleman, and on the regular CT follow-up for the treatment of lung cancer, he had a CT scan, and we found aortobiliac aneurysms. So he's still on chemotherapy, and also he has extensive lung cancer. So I think the open repair, is not the right choice, and he wants to be treated with endovascular treatment. So actually, the aorta itself, it has long landing zone, and so I think aortic aneurysm is not a big problem to be treated with the endovascular EVAR. However, he had bilateral iliac artery aneurysm. So the question is, do we embolize both internal iliac artery and extend the stent graft to the external iliac artery? Or, if possible, we can use, whether we use iliac branch device, IBD, in this case. So what do you think about these treatment options?
Okay, Dr. Ko, we have 10 panelists from worldwide, so I'd like to ask some question to the panelists. Any this is the main problem is the bilateral iliac artery aneurysm. And so, any comment or question?
This is Bill Gray, a very nice presentation, difficult case.
Yeah, good morning. Yeah.
Have you considered potentially doing a unilateral iliac branch device and embolizing the other internal iliac artery? Might make the procedure simpler, but I think either option is better than bilateral iliac artery embolization, which could be very problematic for the patient.
Yeah, I think good suggestion. So I think most patients, tolerate very well one side, embolization. Also, patients, tolerate also very well staged bilateral interiliac artery embolization, but definitely patients suffer from the, ischemia in pelvic zone. So I think, and also there is low risk, but also I think they can be, very critical, crucial. So I think your suggestion is, I think, very reasonable. Any other comment? So our decision was same as Dr. Bill Gray. Could you click the slide?
Next.
Okay, this was our plan. So the left side common iliac artery aneurysm is larger, and also internal iliac artery size is the bigger, so it's not suitable for the landing of side branch stent graft. So we decided to embolize left internal iliac artery with vascular plug, and we plan to implant a iliac branch device on the right side. Our plan was to treat these patients with percutaneous approach, EVAR, using pre-closure technique. And we usually perform our EVARs under local anesthesia and with sedation. So next slide. So the only IBD available in Korea is genus iliac branch, so from Cook. It has different sizes. Important exclusion criteria is the common iliac artery length. So it should be longer than 50 millimeters, and also the diameter of common iliac artery should be larger than 20 millimeters. And internal iliac artery diameter should be smaller than 9 or 10 millimeters, but greater than 6. So I think in this case, next slide. So this is how the whole device configuration looks like. So we will use IBD on the right side, and we'll use genus, the EVAR device from Cook. Unfortunately, we have not the newest version of genus, but old version, genus Flex. So next slide. So this was the baseline aortography taken yesterday, and this is the right side back. Yeah. On the right side, you can see, one more click. Yeah. This is the right common iliac artery with internal iliac artery. So we checked the length of the common iliac artery on the right side again, and I think the length was sufficient. So, and also internal iliac artery looks like it's okay for the treatment with the covered stent. Next. Yeah, this is the left side internal iliac artery. So we embolized the left internal iliac artery with vascular plug, so M+2. Next. And this is our plan. So we will use Cook IBD on the right side, and for the side branch, we'll use a B graft. This is a very flexible, balloon expandable covered stent. For the treatment of the aorta, we'll use genus Flex with diameter 28 millimeter. And then the rest will treat then the iliac limb stent grafts. Next. This is the iliac artery branch. So the important thing is, to place the IBD at the exact, targeted place. So this device has 4 gold markers. So first one should be the proximal edge of the stent graft, and there is 2 markers at the proximal at the origin of the side branch, and the lowest marker is the distal side branch edge. So the distal branch edge should be about 1 or 1 centimeter higher than the origin of the internal iliac artery when we try to select the internal iliac artery. So this whole device is loaded on the caster, and the side branch is already cannulated with the caster, angled caster. And through the caster, we insert a wire, and this wire will be snared by the double snare from the contralateral side, and the wire will be externalized, and along the externalized wire, we'll insert ansel sheath into the IBD and into the into the IBD. And then next slide. Yeah, and then we'll try to select the side branch from the ansel caster from the contralateral side, and then we can insert covered stent through the side branch of the IBD. Next. Yeah, so far this is our plan. Do you have any question about our plan?
No, it's very nice. I just want to make a comment to the audience who may not be familiar with the embolization technique. You did a nice job of keeping the embolization plug proximal in the vessel. If you go too distal, then you cut off many important collaterals from the contralateral interiliac, and you've basically canceled your effect of maintaining patency over there. So that was a nice job.
Okay. So we'll show you what we've done so far. Enjo, please. 처음에 찍은 것부터 보여주세요. Yeah, this is the. We try to find the direction of the gold markers, and then this is the first step. Next. This is the subsection image. So we have to bring the first marker up to the origin of the right common iliac artery. Next. And as you can see on the left side, the internal iliac artery is very tortuous. And we try to open the opening of the already cannulated side branch, and a small side branch, angled branch, the caster is exposed. Next. And then we try to insert a double snare, this indie snare, I think it is from Cook, and to try to bring that into the aorta and try to catch a wire from the angled caster from the IBD. Next. Yeah, but the position of the the snare was not optimal because of the tortuosity of the left iliac artery. So we had at the time short sheath. So we decided to change the sheath to the longer one, and then we could overcome the tortuosity of the iliac artery. Next. Yeah, so you can see the left iliac artery is more straightened now, and we were able to catch the wire from the the angled caster, and we externalized the wire through the left sheath. Next. Okay, we externalized the caster through the left femoral artery, and then next, and then it's like a pull-through technique. We pulled the wire and caster through the IBD to the distal, and we pushed the ansel. This is 12 French answer sheets into the IBD direction. Next. And we first deploy the proximal part of IBD. It's a little bit difficult to recognize the opening of the proximal segment of IBD, but it's now opened. Next. And this pull-through technique, we try to insert the answer sheets into the side branch of the IBD. Next. So we check the opening of the right internal artery. Next. And then with wire, we try to select the right internal artery like this. And next, we changed the wire into the more stiff wire. Next. Next. So now we have placed the B graft. This is balloon expandable covered stand. So this is what we've done so far. So you can see here the IBD already placed, and the B graft is now in the side branch and in the right internal artery, and the position the position of the B graft should be the marker, the distal marker of the or the proximal marker of the B graft should be between the second and third marker. So I think the position of the B graft is okay. Maybe I can push a little bit more. Yeah, I think this is good. So the diameter of the right internal artery is 9.5, and this B graft has diameter of 10, and the nominal pressure is 8. So we'll implant the B graft now. Okay, nominal pressure
2, 4, 6, 8.
8. Okay.
8입니다.
Dr. Bill,
Yeah.
we have not many options for only balloon expandable stent graft, so you usually use the
well, in Korea we
self-expandable?
don't have the Viaban, so Viaban will be my first choice because it is very flexible. But here we don't have Viaban. We have 2 balloon expandable covered stent and 1 self-expandable stent graft, but the profile is bigger with the self-expanding stent graft. So I think we can check the angio. Yeah. The sealing of the internal artery stent graft. So subsection. Okay. Yeah, I think it looks good. What do you think?
Yes, looks very good.
Yeah, so we can remove the whole system. 자, 이거 빼고 둘 다 뺄게요. 테르모 주세요. 테르모 스틱, 카테터랑.
저캔이랑 테니스트.
Okay. And we can remove. 응? 이거? 이거 풀고. 다 됐어. 이렇게 다 됐는데? 오케이. 와이어 잡았어요? 응. 와이어 잡아주고 좀 빼고. 오케이, 여기까지만 합시다. 오케이. 자, 다음에 카테터하고 테르모. So now AP we'll try to implant the main body. 와요. 자, 런더 키스트 주세요.
You're using a Lunderquist or Meyer wire?
런더 키스트. 그다음에 마커 피케 준비해 줘야 돼요. 자, 이거
네.
빼고.
네.
So for those of you who don't do this routinely, they're now exchanging for supported wires in both limbs, and they'll
자, 이거
implant their
뺄게요.
main body, and then he's already got a contralateral limb in.
이거 좀 띄워.
So that job is
빼고.
done, and I'll put the main body up to the left, or the right, sorry, and extend whatever he needs to on
Okay.
the left, which he probably will.
자, 픽테일하고 이쪽으로 줘야 돼, 이쪽으로. 치스 장갑 하나 같이 주면 돼. 됐어. 오케이. So aorta part is actually a straightforward part. So it has a long landing zone. Okay, so we place a marker pigtail from the right side. 자, 메인 바디 주세요. So, okay. So the Zenith Flex system has a delivery system of 20 French. And I think the newest one is Genus Alpha. It has a slightly smaller profile. But unfortunately, in Korea, we have only the old version. So this is the main body. And okay, this. So we'll take a picture. So this I can bring the picture a bit higher up. Okay. 조금만 앵글레신 주고. So 테스트 살짝만 해볼까요? 테스트. Okay. Yeah. Okay, so angiogram, aortogram. Let's go. Yeah. Okay. So I think on this view, the right renal artery seems to be a bit lower. But since the aorta length is okay, long enough, I think. So we'll try to target the right renal artery origin. So we check the direction of the main body. So now, yeah, it's okay. So I'll bring up the main body a little bit higher. So you can see, you don't see the marking, our marking on screen, but so I see the marking on my screen for the right renal artery origin. So I think this is the right position. So I'll try to deploy the main body.
Sorry, the alignment is good? Alignment.
I think it's still good.
Okay.
So the opening of the right, the contralateral side is okay. So the direction is okay.
Okay.
So I tried deploy the first two segments, and then I'll check with an aortogram. the position of the main body. Okay? 자, 셀 조금만 드릴게요. 자, 에어토그램. Yeah. So what do you think? I think this is okay.
Yeah, very
Looks
good.
good.
Yeah. So, okay. 자, 그대로 놔두죠.
And for the audience, there's a little check marker. He's just about to uncover it. That's the contralateral limb opening. Right down there.
Yeah.
See it?
So now the contralateral side is now exposed. So I will try to select the contralateral segment of the main body. 저거 뭐야? 스티프 줄래요?
스티프, 네. 테르모스티프.
Yeah, for this I need to have much luck. Please keep your fingers crossed. Okay. I'll try with the pigtail first, but if not good enough, then I will exchange to other casters, angled casters.
Doctor, you did not open main body.
Not yet.
Yeah.
So it makes more stable.
Yeah.
Dr. Ko, I'm Sang-Soo Lee from Busan National University Yangsan Hospital.
Yes.
Why do you open the top cap? Is first of all, I think it's a fixation for proximal leg.
So you mean deploy the proximal part
Yeah,
first?
yes, first.
Yeah, yes, I think that is
Because a
also
little
an
bit
option.
movement in the proximal
Yeah,
leg.
yeah, okay. Let's do it. 이거 돌리면 되죠? So, okay.
Yes.
So, are you happy now?
Yes, great job.
Okay. It's a joke.
You know, getting into this contralateral gait can sometimes be challenging, and because the aneurysm space is quite large.
코브라 캐스트 있을까요?
And some little tricks can be that before you put the graft
이거
in,
좀 빼줘요.
you watch the natural trajectory of the wire. And if it tends to go across the aneurysm, then you can turn the gate around so that it actually naturally goes in that gate. Here, there doesn't seem to be a preference for the wire, so I'm not sure that would really help. A steerable catheter will be very helpful. That's what's going to happen here.
Doctor, your plan, right now your patient is local anesthesia with sedation, right?
Yes.
Yes. It is special for this patient for lung problem, or every EVAR
That's our
procedure doing
routine
the
in-
local
yeah, no.
with the sedation?
Yeah. That's our routine. Yes.
So, Seung-jun, could you tell us your protocol for the sedation, the light sedation, like agent or?
Right sedation. Actually, I don't actually recognize the regimen, but we call it MAC anesthesia, which is the monitored anesthesia, which is the combination of the painkiller and sedation. He is conscious, but usually feel free from the pain. So we utilize this method in every kind of the endovascular procedure, including TAVR.
Okay.
There we
So-
go. Nice job.
So you supported by the anesthesia?
Oh yes, actually, specialized anesthesiologist dedicated for our hybrid operating room always covers our endovascular case.
So I think the wire and the caster is within the stent graft, so I can prove that while by rotating my caster. So the
Okay.
caster rotates very freely. And also, we can check that with the contrast dye and then see whether the dye stays within the stent graft. But I think I'm pretty sure that the wire is now in the stent graft. So, run the case now.
I did most of my EVARs under local anesthesia with conscious sedation. Did not require anesthesia to be in the room unless the patient was particularly problem. It's doable with the right lidocaine.
Yes. So we have we are doing our procedure in our one of hybrid operating room, and our anesthetists are always very helpful.
Yes, it's nice to have them there.
Yeah. Usually they are not that reluctant. They are usually reluctant to help us, but in our hospital they are very cooperative. So I will measure the length of for the branched the breaching stent graft. So we have 1, 2, 3, 4, 5, 6. length 얼마? 56? Okay. So we have 56 millimeter length breaching stent graft. So 이렇게 빼고.
Dr. Ko, what percentage of your patients do you think that you use branched endografts on today?
I think it is not frequent. So actually, we have a lot of patients with common iliac artery involvement, but rarely they meet the IFU conditions. I think maybe 10% or something like that. So I think the case we do, yearly is less than 5 cases or something like that. So it is not a frequent procedure. Mm-hmm. But if we do this kind of procedure, I think that is very helpful for the patient.
Yes.
Mm-hmm. So according to the paper, I think only 30% of the patients with iliac artery aneurysm, fulfill the IFU conditions. So we need to have, the better device in the future, I hope.
And how about the data of your hospital for IBD, the patency?
The patency is, I think, surprisingly very good. So in our experience, the patency rate is over 80%.
Quite good.
And even though the side branch is occluded, during the follow-up, usually patients do not have symptoms. They are already conditioned after the occlusion of the side branch. So only we find that on the CT scan. So I think this is okay. 좀 잡아줄까, 앞에?
Do you consider the antiplatelet therapy for the patient using the IBD?
Pardon?
Antiplatelets.
Yeah, sure. It is, I think, important. We try to maintain dual antiplatelet therapy at least for 1 year.
Oh, 1 year.
Yeah. 오케이. 이거 좀 잡아줘요. 이것도 잡아줘. 네. 오케이, 이거 뺍시다. 둘 다 빼도 될 것 같아요. 네. 오케이. And then AP will deploy the ipsilateral side of the main body. Okay, and we need to capture the 풀고 the olive. 이거 올라가면 되죠? 네. 잡아주면. 이거 좀 잡아줘. Okay, now this is captured. 이거 좀 빼주면. 다음에 픽테일 주시고요. So now we have to insert the left, the stent graft for the left iliac artery, the pigtail.
Pigtail?
Yeah. We need to measure the length of the stent graft. For the left iliac artery. So we place the vascular plug on the left, in the left internal iliac artery yesterday, and we checked that today with the electrogram, and the left internal iliac artery is now well embolized. Okay, so 콘트라트로 돌릴까요? So, how much time do we have now?
Actually, this is a very short.
2 minutes.
Okay.
So I think that we see your keynote lecture recording is about 10, maybe.
No, it's the duration of my presentation. Yeah, it's about 10 minutes. Yeah.
So after your
Okay.
keynote lecture, and we'll
Yeah.
come back. Okay?
Okay, great. Good idea. 이거 빼고.
Keynote lecture, please.
Good morning. I'm Young-Guk Ko, working at Severance Hospital, Seoul, Korea. It's my great pleasure and honor to present our EVAR experience. The title of my talk is Long-Term Outcomes of EVAR Within and Outside the IPU. These are my disclosures. Endovascular aneurysm repair has demonstrated superior results in terms of morbidity and mortality compared with open surgical repair in the short term. However, recent long-term outcome data showed higher reintervention rates and aneurysm-related mortality for patients who have undergone EVAR. Especially EVAR outside the instructions for use, IFU, had a negative effect on the outcomes, including aneurysm rupture and aneurysm-related mortality. Korean patients exhibit distinct anatomical characteristics, such as the angulated proximal neck, common iliac artery involvement, and tortuous iliac arteries. Thus, we sought to investigate the long-term outcomes of EVAR in Korean patients with AAA comparing those treated with EVAR within the IFU versus those treated with EVAR outside the IFU. This is the design of our study. We retrospectively collected data of AAA patients treated with EVAR from 2 Korean centers, Severance Hospital and Gil Medical Center, between 1997 and 2021. There was a total of 833 patients, after excluding 287 patients with ruptured AAA, isolated iliac aneurysm, or patients lost to follow-up. We included 259 patients treated with EVAR within the IFU and 287 patients treated with EVAR outside the IFU. The primary endpoint was graft-related adverse events, which was defined as a composite of the presence of type 1 or 3 endoleak, reintervention, aneurysm sac enlargement, aneurysm-related mortality, rupture, stent graft migration, and stent thrombotic occlusion. This table shows the instance of violated IFU components. The most common outside IFU components were neck angulation greater than 60 degrees and neck thrombus or soft plaque greater than 50% in circumference. This slide shows baseline clinical and anatomical characteristics of total population and 2 patient subgroups. Mean age was about 70 years old, and the age in the outside IFU group was slightly younger, was older than in the IFU group. Male gender was present in more than 90%. There were slightly more females presented in the outside IFU group. Hypertension was also combined less frequently in the outside IFU group than within the IFU group. Other clinical characteristics were comparable. The aortic sac maximum diameter and aortic neck diameter were greater in the outside IFU group compared with within the IFU group. The proximal neck angle was also greater in the outside IFU group. This slide shows the procedural data. EVAR was performed percutaneously in more than 95%. Branch vessels such as internal iliac artery were embolized more frequently in the outside IFU group in up to 33% of cases. The devices used for EVAR were similar between the 2 patient groups, except for the Endurant 2 device, which was used more frequently in the outside IFU group. Patients were followed for median duration of about 4 years. The freedom from graft-related adverse events and development of type 1 or 3 endoleak was significantly higher within the IFU group than in the outside IFU group. The freedom from reintervention and aneurysm-related mortality was also significantly higher within the IFU group than in the outside IFU group. Freedom from sac enlargement tend to be also higher within the IFU group. In a Cox proportional hazard regression analysis, older age and outside IFU were identified as predictors of graft-related adverse events. Among various components of IFU criteria, neck angulation greater than 60 degrees was the significant predictor of graft-related adverse event, as well as type 1 or 3 endoleak and reintervention. Neck length shorter than 10 millimeter was the significant risk factor of sac enlargement. In the lower risk population, defined as a patient group with mortality risk less than 1% after EVAR, the incidence of graft-related adverse events and aneurysm-related mortality were still higher in the outside IFU group than in the within the IFU group. These are the study limitations. Our study was non-randomized and retrospective study with potential subselection bias, and the follow-up period was not constant among the patients, and there was a significant number of patients lost to follow-up. Thus, mortality and clinical events might be underestimated. Patients were treated with different devices, making the determination of outcome differences between the devices difficult. The inclusion of different generations of stent grafts in the analysis could potentially have influenced the outcomes. In conclusion, our study revealed EVAR outside IFU was associated with greater number of graft-related adverse events, mainly due to increased presence of endoleaks and aneurysm-related mortality compared with EVAR within the IFU. Severe neck angulation was an independent risk factor for graft-related adverse events, type 1 or 3 endoleak, and reintervention. Thus, adherence to IFU appears to be crucial for improved long-term outcomes after EVAR. Thank you for your attention. Our study was published this year in the Journal of Endovascular Therapy. Thank you.
Thank you very much, Dr. Ko, and we'll come back. We'll come
오케이.
back.
숨 들여 마시고 숨 참으세요. Yeah. So this is the final aortogram.
숨 편하게 쉬세요.
So I think there is no significant endoleak,
Yes.
and flow to the right internal ear artery is okay.
Yes.
So
Dr. Ko, could you one more angio within the main body?
okay. So the dye was a little bit faint. Yeah,
Okay.
it's okay. Yeah. 딱 그대로 놔두고. 자, 한 번만 더 할게요. 네. 자, 숨 들여 마시고 숨 참으세요.
Excellent.
야, 숨 쉬세요. So, do you have any comment?
Excellent result. Excellent.
Yeah, so I think I'm happy with that result. Yeah.
Very good.
This patient is a very tortuous external iliac artery. Do you plan to implant the bare nitinol stent?
That's yeah. I thought about that. So actually, the Cook device is not very flexible, and on the left side, especially.
The risk of the
Maybe we
kinking.
can implant, bare metal self-expandable stent.
Yeah.
Yeah, that's, I think, a good suggestion. Yeah. Okay. Any other comment?
Very nice job.
Yeah, thank you very much. So, I think this was a challenging case. The patient with aortobiliac common biliac aneurysm. So, using IBD, I think we can preserve the flow to the internal artery, so we can avoid pelvic ischemia. So there was, because of the tortuosity of the iliac arteries, we had some difficulty, but using longer sheaths, so we could overcome the problem. So I think the result is acceptable. So we will follow the patient with the CT scan in the next coming years. Yeah.
Congratulations and thank you very much.
Okay, thank you.
시간도 그러니까.
That's good. Thank you. That was terrific. Thank you to my co-moderator and to all the panelists. A terrific session, and look forward to seeing you again in the meeting. Thank you.